Our next speaker is Dr. Eleni Gavriilaki. She is specialized at Hematology Department, BMT unit of Papanikolaou Hospital. Her clinical and translational research focus on complement-related disease with special interest in thrombotic microangiopathy. So welcome, Dr. Eleni. Floor is yours.
Thank you very much. I hope you can hear me well. Please let me know if there are any troubles. I'm very happy and excited to be among you today, and I will present data on transplant-associated thrombotic microangiopathy, or TA-TMA. I have tried to summarize all our current questions in the field, and I will try to provide highlights from the very interesting educational session that we had during the EBMT conference. These are my disclosures. So the basic questions that we are going to try to answer are why TA-TMA occurs after HCT, how we diagnose it now, how we try to stratify severity, and potentially how do we assess response. And we are going to start with a case that in our experience typical of TA-TMA. So it's a 30-year-old male patient, almost 1 year post-haploidentical HCT, that remains under long-term immunosuppression due to extensive steroid refractory GVHD, and unfortunately presents suddenly with neurological symptoms like an apheretic crisis, thrombocytopenia, and evidence of microangiopathic hemolytic anemia with hemoglobin of 7.8, increased LDH, and schistocytes in the peripheral blood smear. So this has a difficult differential diagnosis post-transplant, but I will try to persuade you that this patient really suffers from TA-TMA and may benefit from complement inhibitors as a new treatment in this field. So what do we know about TA-TMA? We currently recognize 3 phases in the syndrome: the initiating phase, the phase of progression, and then the phase of microthrombosis. Unfortunately, we do not have any tools to observe this into our patients. And this syndrome is also recognized as an endothelial injury syndrome because everything happens within the vessels of our patients. And endothelial injury, as we know, is a cornerstone of pathophysiological symptoms in graft versus host disease, but also other life-threatening syndromes post-HCT. However, I will try to summarize the recent knowledge in transplant-associated TMA that has gained a lot of interest. Because we recognize that TA-TMA may have some similar features with other complement-mediated TMAs. We recognize that there are pre-HCT risk factors like older age, prior HCT, some patients that have predisposing complement gene variants that, however, cannot be detected in clinical practice but have been found in some research papers. We have HCT factors, the mismatched donor conditioning regimen toxicity, and then post-HCT factors that together with the predisposal to complement activation may lead to this extreme phenotype. And to dive more into the endothelium and complement, which have a continuous interaction, we have data that we have increased soluble C5b9 as a marker of terminal complement activation, and this may be even more in the urine of our patients, although we rarely study this marker in the urine. We have shown some patients may have increased complement activation that happens with on the cell surface with an assay that is again unfortunately not available in clinical practice. There are some studies showing alternative pathway dysregulation, lectin pathway dysregulation, this genetic susceptibility, but also we know that this is multifactorial and there is this vicious cycle of inflammation, increased neutrophil extracellular traps, and interferon signaling, and together with oxidative stress and lipid dysregulation, we have this cycle of microangiopathy. So this is the three-hit hypothesis as we have already developed it, and this highlights that we do not need only one weapon in this patient. We need to face the whole pathophysiology and especially infections and GVHD, we have to treat them simultaneously with any other treatment for TMA. Now, how do we currently diagnose? There has been a lot of discussion for these harmonization criteria. In my opinion, this is a very important effort to try to move this field forward with all the limitations. And importantly, these criteria have also unified pediatric and adult population. Of course, the criteria need to be adapted and according to our clinical knowledge and also to our personalized approach to our patients. But I think these criteria can be a very useful tool for clinicians. So to summarize, our patient needs at least to have 4 of the 7 criteria. Anemia, and in the criteria there are some suggestions on how to define that this anemia is relevant to causes in these patients, thrombocytopenia with a similar notion, elevated LDH, particularly an increase in LDH, the presence of histocytes, hypertension, and proteinuria. I find them very important features that we neglected sometimes in the past, and these may be early signs of renal damage, and elevated soluble C5b9. This is in the plasma, but at least any complement biomarker may be important. And more than that, these criteria have tried to establish high-risk TMA patients because, of course, not all patients need specific targeted treatment, but high-risk patients are those that really need this treatment. And these high-risk criteria, we rarely find only one, are specified as more than double LDH, more than 1 milligram per milligram proteinuria, any organ dysfunction, which is here also specified with specific manifestations, the elevated soluble C5b9, the presence of GVHD, and here I will try to persuade you that not only acute GVHD but also chronic GVHD may be important, and the presence of systemic severe infection. So there is a lot of discussion about complement biomarkers. They do not have 100% specificity and sensitivity, but I think we have to try to incorporate them in our clinical practice. This can be incorporated especially by the pediatric criteria by the Cincinnati group from Sonata Jotel, and also added in the recent harmonized criteria. We don't have many data, and we have to take into account really increased values. So here, for example, this table summarizes studies that have used this biomarker. In our study, we have found that the level of C5b9 that differentiates TA-TMA from GVHD is increased compared to the level that we use as a cutoff for normal. So we need to have soluble sulfide as a nanogram per ml, and this is easy to get by a commercially available ELISA assay. And we need to take into account values that are really increased. I would say roughly above 500. And these values are really indicative of systemic complement activation. And I think this is also relevant to the literature, and we hope that we will have more data about all that when we have the data from the randomized clinical trial that has been performed in the adult population, and many centers have been participating. Our experience on the incidence has been really stable, I would say, and maybe relevant to the literature before and maybe also after this experience. We have found TA-TMA, and this was with the criteria before the harmonization. 15% of our patients, and I want to highlight that in our experience in the adult population, this is not only an acute complications. We have found it many days post-transplant, many years post-transplant, and this also is in line with other studies. We have to take into account that many studies stop screening for TA-TMA, or some centers stop screening for TA-TMA, and they do not screen patients years after transplant. And of course, we have to take into account that late TA-TMA is more likely have also concurrent chronic GVHD. So these patients need continued screening, and this is highlighted in these two very nice more recent studies. We also have additional risk factors, as we know, other infections that may be triggers of TA-TMA in these patients. And this is one unpublished schema based on the criteria, where we try to highlight what we need for screening of our patients and how we can continue screening after the first year. So, how can we implement severity scoring into clinical practice? I think this really needs a learning curve, and we have known negative predictors of survival. We have to take into account all GI manifestations that have been negatively correlated with survival. This is one of our articles showing actually that patients with intestinal TMA, based on certain criteria for pathologies, have very bad survival without complement inhibitors, and patients with neurological dysfunction, like the patient I presented to you in the beginning, also have a very negative outcome without complement inhibitors. Now we are talking about complement inhibitors, and I will not really dive into this field. I think we certainly need to learn more, but we also need to learn more on how to assess response in our patients so that we can implement all these new tools. And that is why we have established this new consensus document for response criteria. And of course, there are limitations always in these consensus documents, because we do not really have enough data for all decisions that we make in this document. But we have tried to establish it as a mirror of the diagnostic criteria, focusing again on response of anemia, thrombocytopenia, hemolysis, complement activation, and of target organ damage. I encourage all of you to read these consensus documents and maybe try to adapt them to your clinical practice. So, the main message for this response criteria is that our aim is to have a clinically meaningful partial response. So this third line here, this third column because we cannot always achieve complete response, and this was not really our aim for our patients. So clinically meaningful partial response for anemia, for thrombocytopenia, and this is something that we have tried also to set some diagnostic criteria here. And histocytes, LDH, and soluble C5b9, we have defined some percentage of decreases for this value. So when to assess response is also very important. We believe at least at 3 to 6 months, but we have to take very careful follow-up of our patients. Again, we aim to partial response in anemia, thrombocytopenia, soluble C5b9, and histocytes. And we have also defined the organ response according to acute renal injury, proteinuria, hypertension, which is also again something that I want to highlight, and the number of antihypertensive drugs may be very important both in adults and in children. Pulmonary arterial hypertension, pulmonary insufficiency, and serositis have been also defined, and we again want to achieve partial response. I want really that to be one of the main messages in the biochemical, but also organ response and then the overall response. So to conclude, and maybe we can have some time for questions, my ABCDE of TA-TMA, we believe that there is a vicious cycle of endothelium and complement, and we have somehow to stop this vicious cycle. We have always to be alert after transplant. We may need complement biomarkers, and we have tried a lot to improve ourselves in this field, but it's difficult to have them in the diagnostic lab. We need to define severity because not everyone needs specific treatment, but we need to start specific treatment as early as possible. And also we need to evaluate response with every tool that we have and standardize criteria. So thank you very much. I'm very happy to answer to questions now, but also to contact and may potentially also have some collaboration in this rare field that has gained a lot of attention, and potentially we have gained a lot of positive outcomes for our patients. Thank you very much.
Thank you for the comprehensive presentation. So we'll take questions. Yes.
Thank you so much for extensive talk. It was very informative. The question comes to Dr. Eleni is that the timings of TMA sometimes is very confused with GVHD. So here you have these non-specific marker like LDH and other inflammatory markers goes high with the GVHD as well. So when do you suggest to introduce treatment? And even introducing the treatment is very challenging sometimes because you're questioning, shall we push the eculizumab or ravulizumab or some medication? Then what's the best timings in terms to push the button for the medications as well? Thank you.
Thank you very much. I think, and I want to emphasize on that, that you're totally right. And many patients, especially our adult patients, have this GVHD course that may get worse. And then on top of that, they will have the TMA. So I think this is why we need to have close monitoring for those patients and very specifically assess the increase of LDH, for example, or the decrease of platelets that, or anemia that these patients might have. in addition, I think that hypertension, proteinuria, and potentially C5b9, and some organ involvement that has been described in the criteria may be more specific for these patients. And if these patients have these definitions, have anything of that, I would highly suggest to consider specific treatment on top of the intensification of GVHD treatment or treatment of infection. So I think we have to treat everything together and try to start a specific treatment as early as possible. For example, in the patient that I presented to you, we did all the differential diagnoses, treated for potential infections, for CNS infections, but also started with pegcetacoplan in the clinical trial, the phase 2 clinical trial that will be announced, and the patient exited the ICU in 2 days and went really well after that. So I think we have to actually use all our weapons and then try to make a better diagnosis over the days.
Thank you, Dr. Eleni. I have a question. Transplant-associated TMA is becoming a challenging problem, especially in the setup of if you have, coinciding or it's overlapping with severe GVHD, for example, of the gut, for example, and you have some hemorrhagic manifestation. And it's really becoming a challenge, especially if you can't get the C5b9, resulted in a reasonable time. So I wonder, this becoming a really repeated scenario. What would be your approach if you have both, like severe GVHD and suspected TMA?
Yes, I think that addition of any drug that we have available of complement inhibitor would potentially benefit these patients, although we still we need to learn more about these drugs, the dosing, and all these questions that we didn't have a lot of time to discuss. I would use any drug that would be available to me. For example, nowadays in Greece, we have ravulizumab available for these patients, and although it is not FDA or EMA approved, we use it off-label in these patients. And again, the data show that if we give it as early as possible, it may benefit these patients. We have to, regarding these drugs, we have to take attention to meningococcal infections. We have to vaccinate all our patients, although we know that may not generate antibodies, and we have to keep them under long-term prophylaxis. But with the knowledge that we have right now, we may be able to give the drug for 6 months and then stop the drug if we have a clinical meaningful partial response. And we have patients that we had a relapse of the TMA after, for example, 1 or 2 years, and these patients again responded to the drug. The scenario of intestinal involvement, I think, is one of the worst scenarios in these cases, and we have to use all our weapons together with every GVHD treatment that we have available in a personalized manner for our patient.
If there are no other questions, I think we will proceed with our next speaker.
Thank you.
Thank you very much, Dr. Eleni.